ISCP's webinar, A to Z on CV Pharmacotherapy. Today, we have a very interesting session ahead, and we have a very long title as well. It's called Beta Blocker, right? Sotalol versus Flecainide and Propafenone, Do's and Don'ts of Taming the AF Rhythm. So if you have tuned in to our very first A to Z CV pharmacotherapy session, you will know that we start with A, all right, which is for aspirin, and B is for beta blocker. And I'm not sure if some of you had looked at this title before you registered and wondered, is this really a beta blocker, and did someone get something wrong somewhere? All right, so I hope this was a teaser and I'm happy to have more than 100 participants. My name is Grace, and I'm a pharmacist from Puat Hospital, Singapore. And with me today are three very esteemed experts. Okay, firstly, we have our speaker, Prof Dan, okay, who is the head of Cardiology and Electrophysiology. Prof GA Dan is the head of Internal Medicine Clinic at Colentina University Hospital. He is a full professor of Cardiology and Internal Medicine from Davila University of Medicine and Pharmacy, Bucharest, Romania. In just a few minutes, he will be sharing his lecture. After his lecture, we will be having a panel discussion with panelists, Prof Takanori Ikeda. Prof Takanori is professor and chairman at the Department of Cardiovascular Medicine, Toho University Faculty of Medicine, director of the Cardiovascular Center at Toho University Medical Center, Japan. And the last panelist needs no introduction. She is Associate Professor Reentry, Cardiology Specialist Pharmacist, Associate Professor, Department of Pharmacy, National University of Singapore. Just a few disclaimers before we invite Prof Dan to start his lecture. The content of this webinar is copyrighted by the ISCP and should not be distributed without the prior permission of the ISCP. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the ISCP. The live streaming content of this webinar will be made available via ISCP and APSC Facebook and YouTube pages. The European Board for Accreditation in Cardiology, EBAC, grants CME points for attendees who attend the full session. Lastly, you will receive your certificate of attendance upon completing a survey, and this will be sent via email after the webinar. And without further ado, let's invite Prof Dan.
Hi, everybody. I'm happy to share with you my opinions about a very exciting subject just discussed in comparing Sotalol, Flecainide and Propafenone. These are my disclosure, nothing linked to these presentations. What I have the task is to try to understand how, when, and why about antiarrhythmic drugs, to say finally what and to whom. For this, I don't need more than 3 hours. So please be patient for the next 3 hours, because I have a lot of things to tell you about this. Finally, in a usual I have a problem with my slides at this moment. I'll try to make again the share from the point I was. So in the next minutes, I'll tell you about something is wrong again. So I will try to discuss shortly about Flecainide and Propafenone pros and cons as antiarrhythmic agents, about the Sotalol in the same sense, about some safety issues, and about the principles of clinical decision-making with antiarrhythmic drugs. In the first part, I will discuss some electrophysiological and pharmacokinetics problems linked to Flecainide, Propafenone, and Sotalol, namely the sodium channel block, the post-depolarization refractoriness, the use dependence block, and the mechanism for antiarrhythmic action of these drugs in atrial fibrillation, meaning inhibition of reentry, inhibition of trigger rate activity, reduction of repolarization heterogeneity. And I discuss shortly also of reverse use dependence. You know that the sodium channel in normal state has several physiological states. It could be open but inactivated. It could be closed and inactivated, and it could be in the rest state. These conformational changes bring the channel from the closed to the open state. And this is very important in understanding the action of the antiarrhythmic drugs. As you know, the sodium channel has several closing gates and opening gates which permit these conformational states. There is a conception of the modulated receptor hypothesis, and there are two distinct pathways in which an antiarrhythmic drug could link to sodium channel. The so-called hydrophilic pathway, which is using the pore, which is a likely pathway for the Flecainide or Propafenone, require the channel opening or in inactivate states, but open in order to access the receptor. Some lipophilic molecules or neutral drugs like lidocaine can reach the receptor through a hydrophobic membrane pathway, which could see here, and this could explain some differences in acting of these drugs of the sodium channel. What is important to know that the sodium current is very rapidly inactivated during the action of the potential, during the action potential, because sodium channel is a voltage operated channel. Only a very small proportion, less than 1%, do not inactivate, but it is very important because this part of the channels generate a persistent sodium current, which is called INAL for the low, different from the fast current. Why is this important? If we keep in mind the three important states of the channel, open, inactivated, and closed, we understand that some antiarrhythmic drugs like class 1 propafenone and Flecainide drugs link to the channel during the open state and remain in the channel during the inactivated state because they have a slow inactivated, so dissolution from the channel. This is true, and this is regulated in a state-dependent block, which means that as the rhythm is higher, as the blocking is higher. But what is very interesting, if you are looking on the figure, because of the slow dissolution of the antiarrhythmic drug from the channel, the refractory period during the drug action is longer than the duration of action potential. So the effective refractory period is longer than the action potential duration, which is called post-depolarization refractory period, which is a very important antiarrhythmic, but also a proarrhythmic property. This kind of action permits the blocking of extrasystoles and or rapid arrhythmias, is rate dependent. This is a state dependent block, and increase the post-repolarization refractariness. Moreover, if you are looking in this picture, you can see that the dissociation kinetics, the dissolution of the drug from the channel, is with a lower speed as membrane potential is less negative. So it is slow in general, but at more positive rest potential, and this is very important in disease state, we'll see later, the dissociation, which is dependent on the resting potential, is even very slow. The use-dependent block is a result of more available channels, sodium channels, in upper and inactivated state during tachycardia, during high rates. Use dependence is more in the 1C Vaughan-Williams class than in 1B and more in 1B than in 1A, depending on the dissociation kinetics, which is the slowest in the 1C class. The post-repolarization refractariness result from the sodium blockers in the use-dependent state or in disease state like ischemia, because ischemia also produce an increase in post-repolarization refractariness. Potassium channel blockers like Sotalol increase refractariness in a reverse use-dependent fashion, but do not produce post-repolarization refractariness. It means that the duration of effective refractory period is equal with the duration of the action potential. The only exception is amiodarone, which is also not only a 3-class antiarrhythmic drug, but also an inhibitor of the sodium current. If we see this, we understand the antiarrhythmic virtues of these drugs. And I give the example for the ventricle, but the same is for atrium. You know the Purkinje fiber are inserted in the adult myocardium by a tweak. Usually in the tweak, the speed of the conduction is equal. In several pathological processes, like in ischemia, there is a unidirectional block, so the one part of the tweak cannot be accessed by the wave. Instead, it is accessed by the opposite part, creating a reentry, which is typical for ventricular tachycardia in ischemic heart disease. But the same mechanism adapted is functioning in the atrium during atrial fibrillation. Each reentry requires 3 important conditions. 2 pathways, the presence of the unidirectional block, and a conduction speed which should be greater than the effective refractory period in order to reach the unidirectional block out of block when the wave returns to the same region. How are the antiarrhythmic drugs acting in such kind of reentry? If we are looking at the class 1 effect, the class 1 effect increase the effective refractory period, and especially the post-repolarization refractory period, and have a selective block at a more depolarized membrane potential. Because of this, in this kind of arrhythmia, they are acting of 2 important prerequisites of the reentry: the unidirectional block and the conduction velocity. The class 3 antiarrhythmic drugs prolong the effective refractory period more than the conduction time, and because of this, they also abolish the reentry. There is some selectivity of 1C class for the atrium because of several reasons. One is that the half inactivation voltage in atrium is more negative which means less natrium sodium channels availability, and it means more blocking capacity. Second, the rest membrane potential is less negative in atria, and as was already shown, the availability of the sodium channels is less during the less negative potential. So atrium is more prone to 1C class antiarrhythmic drugs. The third is a slow repolarization in atria, which means a less diastolic interval on high rates, which means more available channels for the antiarrhythmic drugs. And finally, in the atrium, the recovery time from inactivation is lower than in ventricle. All of these make atria a very good target for 1C antiarrhythmic drugs. Moreover, in the genesis of arrhythmia, the so-called trigger activity represented by early after depolarization and delayed after depolarization are very important. Especially the early after depolarization is generated by prolonging the action potential duration, by decrease in potassium rapid current, or by increase in sodium length current. Because of the prolongation and because of the long plateau, there is a window of low resistance which generates a calcium current called the window current. What is important? Enhancement of sodium L current and blocking of potassium rapid current are both effective in prolonging action potential duration and determining early after depolarization. And this is especially true in disease states like ischemia, heart failure, or long QT syndrome. Also, enhancement of the L sodium current increase intracellular calcium and can cause delayed after depolarization, which is very important in genesis of arrhythmia, including atrial fibrillation. And finally, the enhancement of the length sodium current leads to activation of calmodulin kinase and creating a vicious circle with sodium current. Another important factor in which the antiarrhythmic drugs are efficient, especially those from 1C class, is the transmural dispersion of the repolarization, which is expressed on the ECG by the distance between the peak of the T wave to the end of the T wave, the so-called TP to E. Transmural dispersion of repolarization is rate dependent and increase in bradycardia. Enhancement of sodium current of the L type increase repolarization refractoriness and heterogeneity. A drug with higher affinity for both sodium current but with a weaker rate of dependence is less proarrhythmic, and this explains why 1B antiarrhythmic drugs are less proarrhythmic than 1C and 1C less than 1A, especially in disease state. Reverse use dependence is in fact an extrapolation of a physiologic phenomenon in mammalian, which has the significance of the inotropic efficacy, and which means that the action potential duration is longer at the lower rate. The blockade of the rapid potassium current produces a reverse use dependence by a similar mechanism. However, in the same fashion, the sodium L current is larger in bradycardia and especially in the Purkinje and M cells of the myocardium. So this means that blocking of this current reduces the reverse dependence. And you can see here in the left panel that blocking exclusively the potassium current will generate the early after depolarization and torsade de pointe, but if we concomitant block the potassium channel and the sodium L channel, we have a prolongation of the action potential duration without precipitation of the early after depolarization. This example is very clear in this patient, this electrocardiogram. You can see here after the extra systole is a long interval. We have here a longer QT that in normal beat. This longer QT increase the dispersion of repolarization as manifested by the TPE increasing. If we give a Sotalol with such kind of patient, the QT is enormously increased with an important increase of dispersion of repolarization. But if we add mexiletine, which is a 1B drug, to this patient, the increase in, which you can see in the bottom panel, the increase in QT and then dispersion is lower. The increase in QT is very important when consider the antiarrhythmic drug, and you can see here several important risk factors like heart disease, age above 65, the female gender, especially consuming the diuretics, and in the case of hypopotassemia, hypomagnesemia, or hypocalcemia, interference with other drugs, cerebrovascular disease, bradycardia, and co-administration of other drugs, increasing the QT interval. Interesting, for the Sotalol, which is mainly class 3 antiarrhythmic drugs with weaker beta blocker properties, the increase in the action potential duration is abolished during ischemia because of the increased potassium extracellularly, and you can see here what is obtained in the normal situation of increase of action potential is abolished because of the increase in ischemia of the extracellular potassium load. So hypokalemia increase the block of the potassium current, and hyperkalemia reduce the block of the rapid potassium current. 2 words about the arrhythmias, the mechanism of both 1C and Sotalol, the 2 words about the risk factors we already discussed, and some data about evidence-based medicine. We already said that in ischemia, there is a lower conduction velocity in the ischemic region. This is very logical. If we are giving a class 1 or 3 antiarrhythmic drug, we transform this slower conduction in a unidirectional block. So these drugs are able to produce themselves a reentry mechanism in the ventricle. Moreover, as I have already said, the block of the sodium current is a selective higher in the polarized cell as in ischemia. So the risk of the proarrhythmia is much higher with 1C medication, but also with Sotalol in patient with ischemia. One special consideration in 1C medication, especially in Flecainide and less extent in Propafenone, is the fact that the Flecainide decreases the wavelengths of the reentry, and because of this, more impulses are conducted to the ventricle, so we are in the risk of the sudden increase of ventricular rate and the risk of ventricular fibrillation. This, of course, could be managed by co-administration of beta blocker in a patient receiving Flecainide and to a less extent Propafenone. One important thing to see that no antiarrhythmic drugs has only an edge of the sword. For example, the potassium blockade made by Sotalol is good in working on the short effective refractory period in atrial fibrillation, increasing the atrial refractory period, but also producing in the ventricle early after depolarization. The sodium channel blockers are good in blocking the delayed after depolarization and also diminishing the short effective refractory period, which is a prerequisite for atrial fibrillation reentry, but also they could increase the heterogeneous conduction in the atrium. So each antiarrhythmic drug should be regarded on the both part of the spectrum. We know that the CAS study reported in 91 a twofold increase in mortality in patients with extrasystole post-myocardial infarction receiving Flecainide and Flecainide compared with placebo. We add to this the two meta-analyses and systematic review made by Lafuente, which demonstrated the low efficacy in controlling rhythm and conversion to sinus rhythm of antiarrhythmic drugs and increased mortality with only Sotalol. This was reviewed in an analysis in Cochrane 2019, which demonstrated the increasing mortality with Sotalol. Moreover, the proarrhythmic long QT effect has an idiosyncratic pattern. It could be issued as 6 days to 1 year, as communicated by Roden and Accarelli. Also, the increase in sympathetic activity as during stress could precipitate torsade de pointe. The incidence of Sotalol-induced torsade de pointe is dose-dependent from 0.3% at 80 milligram to 5 to 7% at higher dosages. This is a reason why in the recent atrial fibrillation guidelines of the European Society of Cardiology, the use of Sotalol was downgraded from one class of indication to 2B class of indication. Moreover, one important problem is hypertrophy. There are few papers dealing with hypertrophy and the risk of antiarrhythmic drugs. You have here one of the most important, published by Chang from Cleveland in 3,900 patients. And you can see here on the survival curve in patients with left ventricular hypertrophy and antiarrhythmic drugs is that different from the myth that amiodarone is protective, you can see that non-amiodarone antiarrhythmic drugs have a longer life expectancy than amiodarone. And if we compare amiodarone with non-anti-amiodarone and with class 1 antiarrhythmic drug, we can affirm that class 1C antiarrhythmic drugs were associated with better survival in patients with hypertrophy compared with amiodarone, which is different from the classical view on the problem. 2 words of the how to decide in practice in several minutes. The decision node you can have here, if you compare to antiarrhythmic drugs, you can give a value, a utility value, for example, 100 for reduced burden of arrhythmia, 0 for no change, and 50 for adverse event. And from the research of the antiarrhythmic drug, you can know the figure. In this example, for the antiarrhythmic one, we have a sum of 23.5, and for the second of 25, which is a preferred antiarrhythmic drug. In a more concrete example, if we compare Flecainide with amiodarone, if we are referring to proarrhythmias, we give 0.56 for Flecainide for reduced recurrences, 0.44 for no changes, and 0.13 for proarrhythmia. These are figures for Lafuente analysis. If we are comparing this regard, amiodarone is indeed superior to Flecainide. But if we change this decision tree and we put severe adverse event, we have extracardiac severe adverse event for amiodarone, point is 0.33, and in this case, the choice is favorable to to flecainide in comparing this amiodarone. Several general principles should be applied. In a patient indicated to antiarrhythmic drugs, we should calculate, we should see if the symptoms are important enough to justify antiarrhythmic drugs, because the antiarrhythmic drug therapy in atrial fibrillation is symptom and quality of life related. Usually, we don't advise to start antiarrhythmic drug for the first episode, except the first episode is very badly tolerated. When choosing between antiarrhythmic drugs, do not forget that the majority, except amiodarone, are inotrope negative, so you need to evaluate the impact on ventricular function. The patient should be monitored by ECG indicated as the guidelines, long and medium term, depending on the antiarrhythmic drugs, and the antiarrhythmic drugs combination should be avoided. Of course, antiarrhythmic drugs can be used for shorter period because before electroconversion to facilitate cardioversion. And in the final, we need to take in account that the CAS population has changed. And you have here the TREAT-AF study, which compare Flecainide and Propafenone with Dofetilide and Sotalol in clinical practice regarding hospitalization for atrial fibrillation and hospitalization for cardiovascular disease. And you can see that Flecainide and Propafenone are superior to class 3 Sotalol and LD, Sotalol and Dofetilide. Moreover, there are several pleiotropic effects of the sodium channel blocker, because the sodium channel blocker like Flecainide or Propafenone make less calcium available in the cytoplasm, and this reduces the stress of the mitochondria, as demonstrated by several papers and synthesized by Etienne Elliott and other in European Heart Journal several years before. Finally, the efficacy of antiarrhythmic drugs in maintaining the sinus rhythm is quite modest. Only amiodarone is roughly 60% in 1 year, but the other are at less efficacy. However, as shown recently in the East Aflet trial, it is very important to catch the sinus rhythm as soon as possible after the atrial fibrillation. And you can see here that the early rhythm control is accompanied by 22% less death, stroke, or hospitalization. What is important to show is that in this study, Flecainide and amiodarone were the most used drugs together with atrial fibrillation. So I'm finishing here. Thank you for your attention. I remember you 2 words. One is from my teacher and friend, Philip Kumel. Antiarrhythmic drugs are poison, which sometimes may help. And other is from another teacher I have, Günther Breithardt. Antiarrhythmic drugs are like matches, should be kept away from children. Thank you very much for your attention.
Okay, thank you very much, Prof Dan. I was really smiling at the last slide. So we've heard a lot about how the how the drugs work, how we choose antiarrhythmic drugs, and for the second half of this webinar, we want to use some cases to illustrate how to put into practice these points. Okay, and then to start off the discussion, we have 2 rather controversial cases, okay, which I will introduce, okay, and I will get our panelists to take the case apart and to see how we can apply what we've just learned. Okay, so this is the first case, all right? I'll just briefly read out the case. Okay, so this gentleman is a construction supervisor. Okay, he spends 8 hours per day outdoors in the sun. Okay, and so having this outdoor job, I'm not sure whether there are some alarm bells that are already going off in your head. This gentleman has ischemic heart disease. He has a history of inferior STEMI in 2015, found to have triple vessel disease, and had PCI done to his mid-RCA. He has a bit of residual mid-LAD and distal circ disease as well. When he came, he had so his last echo, right, was a dobutamine stress echo, okay, which found that it was negative for ischemia. He did not have a regular echo done, okay. There were normal LV dimensions. There was LV hypertrophy seen, dilated left atrial mile, MRTR and PR. Okay, he attained 115 maximal predicted heart rate. There were isolated ventricular ectopics and couplets with no high grade of arrhythmia, no inducible wall motion abnormalities, and no chest pain. So this patient also had AF noted post PCI back in 2015, right? But it was converted back to sinus rhythm after a shot of IV imiodarone. Okay, this was later oralized to bisoprolol. Okay, so in 2021, okay, so where we are right now, he was found on a cardiologist visit to have AF on ECG, right? At this visit, he was switched from his regular medicines of bisoprolol 2.5 once a day to Sotalol 40 milligrams twice a day, and he was on aspirin, right, because of the ischemic heart disease. Because of the AF now, he was switched to rivaroxaban. So this is his ECG when he came, all right? You can see the AF there. These are some of the investigations. HB, hemoglobin, platelets, okay, all within normal limits. The sodium, potassium, his EGFR is 40 to 50, noted gradually reducing from the past year, okay? His CVRF, cardiovascular risk factors are as such. Okay, liver and thyroid function tests are within normal limits. Right, so this is an actual case, all right, where the patient went home with Sotalol 40 milligrams twice a day and rivaroxaban 20 milligrams once a day. So to kickstart our discussion on B beta blockers, okay, first question which I would like to open to the panelists. Perhaps I can start with Prof Takanori. Do you think antiarrhythmic drug is needed for this patient? And noted Prof Dan had said likely not for first episode, okay, but we do see some benefit of early rhythm control, right? Hope you can share what you think. Prof, you are muted.
Okay, Grace, before I answer the question, I would like to make sure whether or not this patient has some symptoms or AF. No symptoms?
Okay, right. So that's a great question. So the patient did complain of some giddiness and palpitations. That's why the ECG was done.
Okay, yep. Sure. Okay. So my answer is rhythm control therapy, including antiarrhythmic drug, would be needed in this patient. Although this patient has no significant symptoms, this patient is 61 years old, relatively young. As you know, long-term persistent AF makes functional valvular disease, pulmonary hypertension, and so forth in the future. So I think restoration from AF and the maintenance of sinus rhythm will be desirable. But I think catheter ablation should be also considered as another option. That's my answer.
Doreen, did you say something? You are muted as well.
Nope.
Oh, no. Okay. All right. All right. So we have a suggestion also that the patient should be offered ablation, right? Prof Takanori. Perhaps, Prof Dan, would you offer this patient ablation?
You know, this kind of patient, please, yeah, Professor Dan, yeah.
Sorry, Professor Takanori. First of all, before deciding But before deciding, I prefer to think. First of all, I would ask what already Professor Takanori asked, if the patient is symptomatic.
Right. Okay.
Because I have already said that the only reason for a therapy with antiarrhythmic drug in such kind of the patient is a symptom control, and in several cases, but it is not this case because the rhythm is convenient, is preventing the tachyarrhythmopathy. Of course, I do not mean by this that atrial fibrillation is as good as sinus rhythm in a patient with ischemic heart disease. It only says that we have limits of the current methods in order to treat the patients. The only difference between ablation and antiarrhythmic drugs is in quality of life. So before deciding if I prefer ablation versus antiarrhythmic drug, I evaluate the duration of episodes and the total burden. For example, if the patient is on the short paroxysmal episode 3 times by semester, I am not very fond of intervening in this regard, and maybe if symptomatic, I prefer the ablation. If, on the contrary, the patient has 3 episodes on a week, this is clear that it is better to intervene, especially if the patient is symptomatic. To be short, answering directly to the question, is patient could be indicated to antiarrhythmic drug if it is symptomatic, and because it is quite young, the rhythm strategy could be followed. Sotalol could be an alternative in this patient, but I'm not very fond of it. And mostly because the left hypertrophy is a risk factor also for the Sotalol, because the beta blocker effect is weak in the Sotalol. It was, bisoprolol was replaced by Sotalol. And the second and the most important reason is because you have presented in this case a decrease in the renal function. This put the patient in a very fragile situation.
Okay, so if I may summarize, the very first learning point for us today would be to talk about symptoms. Okay, right. So one of the key things between rate and rhythm control, okay, which I have not put in this case, okay, for us to discuss, is the presence of symptoms. Okay, and number 2, to individualize it, we would look at for things, for example, renal function. Okay, so we have this sorry, hang on. Okay, right. So we will also talk about if the patient was symptomatic in this case, maybe about having 3 to 4 episodes per week. Maybe we would like to also look at what else we would use if Sotalol was not a very good choice. All right. So I suppose, as Prof Dan has shared, because of the CAST trial, okay, patient has contraindications to propafenone and Flecainide, all right, and for the LVH noted as well. So I suppose the only agent that we will consider if the renal function continues to deteriorate will actually be amiodarone. Okay, if the patient is, so what happened for this patient was actually he was offered amiodarone, okay, but because he spends 8 hours a day outdoors in the sun, okay, when he was offered amiodarone, he was very concerned about the dermatologic side effects. Okay, I would like to ask, if your patient had told you this, what would you have explained? Yeah.
I'd like to comment, short comment about the contraindication for Flecainide and Propafenone in hypertrophy. It is quite a classical contraindication, as already shown. If the hypertrophy is not enormous, so less than 14 millimeters per free wall, it is not a real. But I agree that in ischemic atrial fibrillation, maybe Sotalol is a better indication, keeping in mind also that the Sotalol is very proarrhythmic, especially in the low heart rate, and the patient has a low rate in atrial fibrillation, and especially if other medication could increase the QT interval. But the ischemic heart disease is maybe the only indication for the rhythm strategy with Sotalol I would accept.
Okay.
I
All right.
Also, I would like to have a comment, okay? With respect to LV hypertrophy, firstly, I will consider administration of a beta blocker, such as carvedilol and bisoprolol, because these beta blockers have an effect of cardioprotection. Unfortunately, Sotalol does not have such an effect. If heart rate and blood pressure are not so low, I will add a beta blocker.
Oh, okay.
I mean, the beta blocker is a carvedilol or bisoprolol, not a Sotalol.
Okay. Right. Means to actually keep on the beta blocker and increase the dose to help to control for their effects on the BP and hypertrophy. Okay. All right.
Okay.
So with regard to counseling on drug side effects, maybe I will invite Doreen to share her comments. So if the patient had come and asked in the pharmacist clinic, I read about dermatologic side effects of amiodarone. I'm outdoors in the sun all the time. I don't like amiodarone. What else can I use? Would you have any thoughts about that?
The most difficult controversy that should have been asked to George Dan. he'll give a better answer to this. Okay, so
Okay.
I'm thinking that so we've talked about a few scenarios with this gentleman over here, right? One of them is that he's on Sotalol now, and we are not very keen on Sotalol, mainly because of its deteriorating renal function. That's the main thing, and also the ischemic disease from before. But also weighing the fact that between Flecainide and then Propafenone, Sotalol seems the least of the three evils right now because of the renal function that's deteriorating. And that's why I think Professor Dan did say that he would accept Sotalol for this particular scenario. Of course, the other possibility is mainly to think about amiodarone, and the fact that he's in the sun would predispose the person to, say, the dermatological side effects from amiodarone. I'm thinking that this is something, hopefully, that a patient can understand, that we can explain to them. I do think that the amiodarone dermatological effects is not across the board to everyone. We could potentially ask him to either cover up with clothing, like what he's doing in this picture over here, or we could ask him to put on sunblocks. Of course, all things being equal, right, the potential of him, assuming he was symptomatic, that could also be considered to send him along for ablation if that's something that's agreeable for him. I think the key thing at the end of the day is really, if we force a patient to take something that they're not comfortable with, we can shove it down their throats, we can prescribe it. But if they go home and they don't take it, then the drugs are actually useless for the patient per se. So in a roundabout way, I've sort of said, yeah, you can try amiodarone if the patient is comfortable with it. But if the patient is not comfortable with it, we've got to give them alternatives, which is going to be, in this case, either ablation, assuming that he's symptomatic. Again, we're talking about cardioversion in the same breath of ablation and the use of antiarrhythmics here, right? So if basically he's symptomatic, we have to think about cardioversion for him. So it's either going to be AADs or it's going to be ablation for him. So if he accepts the alternative, which is going to be ablation, hopefully that's well and good, because that is the least, I guess, side effect profile for him with respect to the comparison between AADs as well as ablation. Yeah, but if he doesn't accept it, then we just have to go with whatever we think is best for him. And in this case, potentially, maybe, there are different points of view here, but maybe Sotalol can be tried. Maybe actually there's no other alternative for him, so maybe Sotalol can be tried, and then we pray for the best for him. At the same time, I think it's important to counsel him, because he works outdoors. If he goes on hikes and all that and he gets symptomatic with his AF runs, he might actually lose consciousness and he may fall from height, and that's also a job related risk that we have to talk to him about.
Okay, for two cardiologists, it seems that amiodarone has a list of 10 side effects, while Sotalol only has maybe 3. How do you explain this to your patient? Maybe Prof Takanori, you had some thoughts. If a patient had shared that he's concerned about the many side effects of amiodarone, how would you try and explain this to the patient?
Yes, regularly I will check firstly thyroid function and also check the X-ray. Some abnormality, the shadow is present or not regularly. That is quite important. Otherwise, we have a patient have interstitial pneumonia. That is a very, very severe side effect. Regular check, that is quite important when we use the amiodarone. In other words, Sotalol, we have to check regularly QT interval prolongation because as Professor Dan stated, Sotalol has a reverse use independent blocking action in QT in prolongation. That is quite important to use Sotalol. That's my suggestion.
Okay. Right. Any more comments about this case? If not, we will move on to another one. Okay. So taking note of the time, all right, we have another AF case, all right. So this is a lady now, all right. This is an office clerk, all right. She has no past medical history, not on medications and no allergies. So now everyone knows that we must look for symptoms, right? So she presents with a 1-day history of palpitations and mild shortness of breath. This was her ECG on the first day when she came to the emergency department. She was given a quick shot of diltiazem. And the next day when she was in the ward, her ECG is as follows. Okay, so on her echo, right, she has an EF of 65%. Okay, dilated left atria, and the other details as follows. All right, she has hemoglobin, platelets, and blood chemistry as such. Okay, so note that she does not have now a history of ischemic heart disease. She does not have LVH, all right. So she is given the same prescription of Sotalol 40 milligrams twice a day and with roxaban. Okay, what does everybody think of Sotalol for her? Could we have used any other agent?
Okay, for first question, my answer is that in this patient, Sotalol would not be the best choice because the cardiac function of this patient is completely normal. To prevent a severe side effect of antiarrhythmic drug, particularly Toho due to QT interval prolongation, other 1A or 1C antiarrhythmic drugs, including Flecainide and Propafenone, could be appropriate. That's my answer.
Okay. Okay, Prof, can I hold on to you for that comment? Would you choose Flecainide or Propafenone?
When we compare between Flecainide and Propafenone, I may choose Propafenone because the Propafenone have also a beta blocking action, though it is not so strong. If we use a Sotalol, the dosage, Flecainide, I will, add beta-1 blocker, such as a bisoprolol.
Okay. Right. So you will use, if I hear you right, you will use Flecainide with bisoprolol.
Yeah, right. When we use Propafenone, that's it. When we use Flecainide, we will add bisoprolol. That's my answer.
Okay. And would you use Flecainide and Propafenone as pill in the pocket or regular?
Probably that's in that case. In this case, if patient have frequently some symptoms due to some palpitations, regularly I will prescribe. But very rare, occurrence of AFib. In that case, is like a pill in the pocket, or that's temporary. I will use antiarrhythmic drugs.
Okay, thank you, Prof. Dan. You had some you had some more comments about this. Flecainide or yeah.
I don't want to disappoint you, especially Doreen. I don't want to disappoint. But my opinion is quite different here. And please let the ECG, because I will comment a little bit the ECG too. First of all, as I have understood from this case, this is a first episode of atrial fibrillation. I never give antiarrhythmic drugs for the first episode of atrial fibrillation. This is an illness in the physician population to give antiarrhythmic drugs from the first step, because I need to know what kind of atrial fibrillation, how frequent is it. It is the first and the only episode. This is a reason for which the European and American guidelines introduce the term the first atrial episode, because for some persons, the first is the last also. I admit that it is a minority, but it could happen. Second, so for such kind of patient, if she is symptomatic and she was symptomatic, I prefer the rate control strategy, at least for these episodes, and I wait. Usually in my office, I demand to wait for at least 1 day to wait for the spontaneous conversion to make the difference between paroxysmal and persistent atrial fibrillation. Second, I fully agree with Professor Takanori. In a person with normal ejection fraction, if I have to give antiarrhythmic drugs, which is not the case of this patient, I will never choose Sotalol, because Sotalol is among the only antiarrhythmic we have at this moment, provoking proarrhythmia even in normal hearts. So why to choose an antiarrhythmic drug with less safety profile than other for such kind of patient? Now, if we are looking careful to the ECG, despite the fact that this very nice young patient, I suppose everybody agree, at least I'm here, that 68 is a nice age in the young patient. If you look to the ECG is not normal. It's not normal. No. Yes, this one.
Which part is not? Yeah.
The normal rhythm. The other one.
This one?
The next one.
There are only two. Yeah.
Yes. If you are looking here, I don't want to enter in too much subtleties, but if you are looking in the inferior derivation, this is it is abnormal repolarization phase with a negative T wave, and also in the right derivation, V1, V2, V3, the repolarization phase is not normal. I don't know what is behind this, but it is not normal. Moreover, if you are looking to the QRS complex, there is a minor conduction defect in the right ventricle, a minor right branch block. This is a RSR prime in the V1, V2. This made me very cautious with 1C class, which prolonged also the QRS interval. So for the moment, I will let this nice lady without antiarrhythmic drug. I will control the heart rate if she is symptomatic, and we'll follow in time what happened, and we'll decide the medication. If a normal cardiac function is really normal, Sotalol is not for me the first choice. And finally, your very interesting, very interesting question about the pill in the pocket. Pill in the pocket, I tell to my student, it's for the second episode. For the first episode, we need to understand the effect of antiarrhythmic drug in the hospital. And in the ERA guidelines, I'm one of the authors, and also in the book edited by ISCP about the antiarrhythmic drugs, we made very clear distinction that if we want to choose pill in the pocket for a patient with normal function, with not very frequent episode. These are the indication. The first pill in the pocket is not in the pocket, is in the hospital in order to see their activity, because the dosage of propafenone and flecainide is twice. I have seen the patients with pill in the pocket with a maintenance dose in the pocket. This is not pill in the pocket. This is a drug in the pocket.
I completely agree with Professor Dan. That is very, very useful.
Thank you. I was about to ask George then, as well as Takanori, both professors. If we take one step back, and we're not talking about these two cases, but in general, when you approach a patient and you do want to start some sort of antiarrhythmic agent, what would make the difference between choosing between propafenone and flecainide? Because in all intents and purposes, flecainide seems to have a lot more data around it, probably less with propafenone. But how would you choose between the two, and why would you choose one over the other?
I think that's a depend on the situations. If I know patient have frequently, the atrial fibrillation, there is no relation with autonomic nerve system. I think flecainide is better than propafenone, because the flecainide have a sodium blocking action, and also that has a potassium blocking channel blocking action. That has two actions, channel actions. That is could be useful. That's my comment.
How about Prof Dan? What do you think?
This time I need to be in line. So I agree with what Professor Takanori said, and also I agree that it's very important to answer to your question, because this is a very practical question, Doreen. Until recently in Romania, flecainide was not available, despite I made efforts since the last 10 years to ask the Ministry of Health to introduce flecainide. Now we have flecainide. Flecainide is a little bit, let's say, more efficient in converting atrial fibrillation and maintaining sinus rhythm, has a lot of studied pleiotropic effects, and probably is more suitable for patients with atrial fibrillation and indication for flecainide or 1C drug. Two pearls here. First, if you want to have an effect, flecainide should be used at a just dosage. What I have seen in practice is using the flecainide at very low dosage, and of course, this is without any effect. This is for flies, but not for mans. Second, when using flecainide, especially in patients with known history of atrial flutter, very careful with such patient, and the administration of a beta blocker is mandatory, concomitant use, which is not the case probably for propafenone.
Okay, thank you for answering that last question on flecainide versus propafenone. I think this is something that if you look at the guidelines, they often mention it in the same breath. All right, so I myself learned a lot from this discussion, and I think we may have many more questions for our experts, but unfortunately it is time, right? It is about a few minutes past 7, and I think our experts have their own patients to go and see as well. So with this, I thank everyone for their attention. Okay, we have almost 300 participants here, and I really am very thankful for you tuning in to listen to us for the past 1 hour. All right, so with that, we will end the session. All right, and feel free to send in your feedback after the session as well. Thank you very much.
Thank you.
And goodbye.
Thank you.
Bye.